Okay, I think we'll get started now. Well, welcome everybody to the third CFAR HIV-TB quarterly webinar. As a reminder, the purpose of this is to try to present research, ongoing and recently published work of those of us who are doing work in HIV and tuberculosis in order to increase collaboration and cross-pollinate, so to speak, with respect to research endeavors. This is Greg Bisson. I'm calling in from University of Pennsylvania, and my co-organizers include David Dowdy, Jyoti Rangarajan, with guidance from Ron Coleman and Dick Chason. So the format of this, for those of you who have not been here before, is typically we have a presenter who will give a talk of about 30 to 40 minutes in duration, and then we will have time at the end for questions and discussion. So I'm just going to record this. Okay, it says I'm going to record this so that we can watch this later. Just making sure. Okay. Well, I'll try to get the recording going. Ron, if you know how to record.
You're recording. It's recording.
Okay.
I'm trying to click record and it says I need permission from the meeting host.
It's already recording.
Oh, it's saying recording up in the left-hand corner there. Yeah, so we're recording. Okay, good.
Outstanding.
Good, good. So what I'm going to ask is that our presenter be allowed to present, and then unless there's questions for clarification, which you need to interrupt right away, we can save questions for the end, and then you can just text me with a question, or say that you have a question, and then I'll just call on people as in the order in which I get texted. So you can see on the bottom right there, you can send me a message. That way we'll let Sarah get through. So I'm delighted today to welcome Sara Auld as our presenter. We're going to be talking about TB and HIV co-infection, a view from the lungs. Just briefly, Sara did her undergraduate work at Stanford, her med school at Columbia, and residency at MGH. She then was an EIS officer in International TB branch and spent time not only at CDC, but in South Africa, Cambodia, and Kenya. And then she did her fellowship in pulmonary medicine, so not infectious disease, pulmonary medicine at Emory, where she is now an assistant professor of pulmonary medicine. And I've had the pleasure of working with Sara on some projects related to HIV and TB in lungs. And I've learned a lot from her. So welcome, Sara, and take it away. Just a reminder, it looks like everybody is following the golden rule of keeping muted unless they have something to say. So Sara, take it away.
Thanks, Greg, and thanks everyone for inviting me to present at this. I'm excited to share with you some of the things we've been working on. And like Greg said, I think having this pulmonary background brings a slightly different perspective and focus when thinking about some of these issues around TB, HIV co-infection. I'm excited to share some of that with you. So as an outline for the talk, I'll start out with some background on what we know about pulmonary impairment in TB and HIV. Certainly won't be an exhaustive review by any stretch, given the time constraints we have, but a few examples that really focus on what we know going on in the lungs. And then move into, for the meat of the talk, really some of the key questions that we think are important for TB, HIV co-infection in the lungs, and some of the studies we've been working on as a part of an effort to answer these important questions. Questions like what drives pulmonary inflammation in TB, HIV? We know that host factors are important, what types of immune response people have, but what are some of the pathways that we can focus on there? And then also, how does TB, HIV co-infection impact lung function? I'm admittedly a bit biased, but I think that lung function is a very clinically relevant endpoint, has the potential to impact patients for the rest of their lives, long after they're cured of their TB. And so looking at some of the phenotypes and patterns of lung damage that we see in patients with TB, HIV. And for that, I'll present some data from the LIFT-IRIS study, for which Greg's actually the PI, and I've been working with him for the last couple of years. And as I'll explain, this is a study that really kind of leverages the immune restoration that you get with ART initiation to study some of these phenomena of lung inflammation in a population that we know is at greater risk for some of this pathologic inflammation. And then last, looking at how pulmonary immune responses may differ for people with HIV, I'll share some very preliminary data from my K23, where I've been conducting research bronchoscopies on people with and without HIV here in Atlanta. And then hopefully we'll have plenty of time for some good discussion and questions afterwards. Just as sort of a visual schema for the talk, I think, we would all agree that when we're looking at some of the cellular inflammation, immune responses, and trying to understand those, it's really in an effort to understand the clinical disease and epidemiology that follows on afterwards. And so, again, focusing in on some of these areas of overlap between what we know about TB lung disease and what we know about HIV lung disease, the talk will have these three main sections, looking at lung inflammation and TBI risk, looking at pulmonary function in patients with TB-HIV co-infection, and then moving into some of these newer data on alveolar macrophage dysfunction and HIV. But going back a little in time, the Furlan Sanatorium was in Seattle, and these are some data from 1959 where they did lung function testing on every patient admitted over the course of that year. And what you see on the left is that just over a third of patients had reduced peak expiratory flows. They have maximum expiratory flows, what they say there, but we now usually call them peak expiratory flows. And that's a common finding that you'll see in patients with emphysema and COPD. And then on the right-hand side, they actually broke down the patients into the extent of radiographic involvement they had. So whether they had minimal, moderately advanced, or far advanced disease on chest X-ray. And then they looked at the peak expiratory flows within those three categories. And the shading of the boxes indicates the proportion who had a reduced peak expiratory flow. And not surprisingly, you can see that as you had more extensive radiographic involvement, you were more likely to have reductions in your lung function in that peak expiratory flow. These are some more recent data from miners in South Africa. And in this first plot here on the left, what you see is FEV1 on the y-axis, which is the forced expiratory volume in 1 second, one of the lung measurements that we often collect, plotted against age. And just to state from the outset that everyone has declines in their lung volumes with aging. It's part of natural aging. But what they've shown here is that when you compare miners who've never had TB, who are in the solid line at the top, to those who've had 1, 2, or 3 or more episodes of TB, TB really sort of accelerates those expected declines of age. And this is, and then on the right-hand side, actually, so they show across the bottom the FEV1% predicted, and then on the y-axis is sort of the relative frequency and proportion within these FEV1 strata. And starting at the top, they have patients who've never had TB, and then 1, 2, and 3 or more episodes. And again, you can see that with each episode of TB in what's a very highly exposed population, they're more likely to have abnormal lung function at the end of it. Shifting into the HIV side of things, where I think the whole phenomenon of non-infectious pulmonary disease has been more recently recognized as there's growing awareness overall of the non-infectious complications of HIV. On the left are some data from the cohort at the University of Pittsburgh. And what you see is that respiratory symptoms are incredibly common among people with HIV. Almost 2/3 of people reported some symptoms, whether those are dyspnea, cough, sputum, or wheezing. And then looking down at the bottom there, you can see that smokers were more likely to report symptoms, but even among non-smokers, nearly half actually reported some respiratory symptoms, so much greater than what we would expect in a healthy population. On the right-hand side are some data from the Veterans Aging Cohort Study, and these are incidence rates for these various pulmonary diseases. And what you see here is that almost every major pulmonary disease is overrepresented among people with HIV. The infectious ones like bacterial pneumonia, PCP, and TB much more so, but even, again, these non-infectious pulmonary sequelae like COPD, like pulmonary hypertension, like fibrosis, are more common in people with HIV. And this paper, which came out last year, shows that these reductions in lung function actually matter. So decreased lung function was associated with greater all-cause mortality in these people with HIV. So if you have HIV, and they did some adjusted analyses where they controlled for other clinical variables, if you have HIV and reduced lung function, you are at greater risk of death. And then moving into some of the mechanisms that underlie this, there's certainly an extensive literature on the many pathways that can drive some of this immunopathology. For the purposes of this talk, I've kind of cherry-picked, and I'll be highlighting matrix metalloproteinases, MMPs, as an example and a common thread that will appear throughout. And it does seem to be driving some of the local pathology that we see within the physiologic compartment of the lungs. So first, these are some data from TB. They recruited patients who were coming in with respiratory symptoms and undergoing bronchoscopy. And so the first plots here are from bronchoalveolar lavage samples. And what you see is that patients who were diagnosed with TB had higher levels of MMP1 in their BAL than patients who were coming in with similar respiratory symptoms but not diagnosed with TB. And then in the middle there, they broke it down by, again, radiographic involvement. And those who had more extensive involvement on chest X-ray had higher MMP levels. So showing, again, some of that connection between the actual tissue findings and maybe what might be mediating some of this. On the right-hand side here are some data from a mouse model they created. Apparently mice don't have an MMP equivalent, so they created some transgenic mice with who would express MMP1 in activated macrophages. They then exposed these mice and their wild type littermates to TB, and what you see first there is that the transgenic mice who are expressing this MMP, after getting exposed to TB, had significantly less collagen area in their lungs. And that bears out in the histopathology that you see on the right there. The top is the wild type mice who have these nicely preserved alveolar structures. Despite a lot of inflammation going on, all that sort of hazy orange is going to be an inflammatory infiltrate, as compared to the bottom where they're expressing the MMP and it's really just obliterating those alveolar spaces. And so certainly these data are some of many data that suggest that MMPs might be mediating some of the lung damage and collagen destruction that we see in TB. Similarly in HIV, and I've again tried to find examples from human subjects, these are from bronchoscopies that were done on people with or without HIV. And for this study, they focused specifically on HIV-infected smokers who had early emphysema. You can see on the left that their alveolar macrophages had nearly threefold greater expression of MMP9 as compared to people without HIV, and that's even those HIV-negative smokers also with emphysema. And then on the right-hand side, they looked at MMP9 protein levels in the epithelial lining fluid, which is essentially a sort of normalized version of the bronchoalveolar lavage. And this was also significantly higher in the people with HIV. And so just as in TB, these data suggest that MMPs might be playing a pathogenic role in HIV-related lung disease. And so thinking about lung disease and those with TB and HIV co-infection, there's certainly potential for overlap and synergy for some of these underlying biological pathways. And we wanted to focus in on lung damage in people with co-infection who are really a unique group. They often have less lung involvement at presentation and then have a dramatic uptick in inflammation after starting ART. Clinically, we think of that as often as TB iris. And there's been a lot of work looking into risk factors for and drivers of TB iris as a syndrome, but overall less focus on the lungs and the potential for end organ pulmonary specific inflammation and damage. And so with the LIFT iris study, the lung impairment after TB iris study, we wanted to study this. As I mentioned, Greg is the PI for this study. And some of the key questions that we wanted to really hone in on with this are whether immune restoration with ART leads to an increase in pulmonary inflammation and injury. So obviously we want people to be reconstituting their immune system, but are there pulmonary sequelae that might be less desirable? And then if so, can we study some of the potential drivers of this lung damage? So the study's a longitudinal cohort study. We actually just completed the last study visit this past summer. Participants were enrolled just outside of Johannesburg, South Africa, in collaboration with colleagues at the Orem Institute. And these were adults who were newly diagnosed with HIV and gene export positive pulmonary TB, who were initiating ART and TB treatment as per South African national guidelines. Study visits were done at baseline, which was between the time of starting TB treatment and ART initiation, with follow-up visits at 4, 12, 24, and 48 weeks. And so those last two visits happening essentially at the end of TB treatment and then even 6 months after that. We did patient interviews, did a clinical assessment for TB iris, collected samples for CD4 count, viral load, PBMCs, and plasma. We administered the COPD assessment test, which is one of several symptom tools that are available to assess respiratory symptoms. And then did spirometry, which I'll talk a bit more about on the next page. And in a subset of participants, we also did PET-CT scans. And so since I suspect this isn't an audience that thinks about spirometry quite as much as I do, just a quick review and recap. The FEV1 is the forced expiratory volume in 1 second. And so how much air someone can blow out in the first second of exhalation. The FVC is the forced vital capacity, and so how much air someone can maximally take in and blow out. And clinically, we usually look first at the FEV1 to FVC ratio. If that's less than 70%, the person will be classified as having obstruction because it takes them longer than expected to get air out of their lungs. And among those who have obstruction, the FEV1 can be used to gauge the severity of that obstruction, with a lower FEV1 indicating worse obstruction. We then look at the FVC to see if the overall lung volumes are big or small. Lung volumes that are big can indicate hyperinflation, which would support a diagnosis of obstruction. And lung volumes that are small suggest restriction, with a lower FVC corresponding to worse restriction. And then just of note, both of these measures, the FEV1 and FVC, can be reported as either absolutes in terms of their volume in milliliters or liters, or they can be normalized to age, gender, height, and race, in which case they're reported as percent predicted values. And so you can see the flow diagram on the right, where with various combinations of the FE1-FVC ratio and the FVC percent predicted, you end up in one of these buckets of diagnoses. And then just a quick minute on PET CTs, and this is an example from the LIFT-IRIS study. These essentially overlay a traditional CT scan with a PET scan, so you get to combine anatomic information with information about cellular activity and uptake of radiolabeled glucose. And so here you have what we would call a sort of hot TB lesion with a standardized uptake value, that SUV of 8, as compared to normal lung, which would be much lower at 0.5. And by combining the SUV data with the volume measurements of the lungs, you can end up with a metric called the lung total glycolytic activity, or TGA. And you'll hear me talk a little bit more about that in a minute. And so here's the basic characteristics of the cohort that we enrolled. We started with 135 participants. And I just want to draw your attention to a couple of things. First is the smoking status of the cohort. So about 16% reported current smoking, which interestingly is just about what we have here in the US, with 40% reporting ever smoking. But the actual amount of cigarettes smoked is pretty low. So this is the pack years that they smoked, which was 2.8. And the pack year measurement takes the number of packs per day times the number of years someone smoked. So someone who smoked a pack per day for 20 years would have a 20 pack year history. And so 2.8 is really a pretty low amount of cigarette exposure overall. And then the other thing I just want to highlight is that this is a very immunocompromised cohort. So again, they were newly diagnosed with HIV, not yet initiated on ART at the time of their baseline visit. And the baseline CD4 counts were, the median was 110. And so now shifting into some of the results, here are some plots that show lung inflammation as measured by the PET CTs versus lung function. And across the top row, what you have on the y-axis is the lung total glycolytic activity at baseline, which would again be prior to ART initiation. And that's plotted against the lung volumes of the FEV1 and then the FVC. And you can see that inflammation on PET CT was inversely correlated with lung function, so that those with a lot of PET activity would have lower lung function at baseline. And then across the bottom, these are plots of correlations of change. And so the y-axis here is the change in lung total glycolytic activity between baseline and 4 weeks, which is when a second PET CT was done. These changes in inflammation are plotted against the change in lung volumes during that same time period. And what you can see is, again, this inverse correlation, where an increase in lung inflammation after starting ART was correlated with a decrease in lung volumes during that same time period. So these show not only that there is indeed lung-specific inflammation happening after ART initiation, but that this inflammation is consequential in terms of lung function. To get into what might be driving some of the inflammation, we next looked at the lung total glycolytic activity on the PET CTs and PPD-specific CD4 cells. And among those with an increase in their lung total glycolytic activity, again, between baseline and 4 weeks, who are shown in red here, they were significantly more likely to have an increase in interferon gamma and TNF-alpha producing TB-specific CD4 cells during that same time period. And there was a trend towards an increase in the IL-2 producing cells during that same time. And so this suggests that at least some of this increase in lung inflammation that we see after ART initiation, which again is correlated with lung function, might be driven by increases in these CD4 cells. And next, we wanted to just focus in on the lungs a bit more and look at what I'll call respiratory TB iris. And just of note, only 6 participants in the study met criteria for conventional TB iris. But if we looked at the number of participants who had a drop in their FEV1 of at least 100 milliliters, which is the MCID, the minimum clinically important difference in COPD, what we found was that half of participants had a clinically meaningful decline of at least 100 milliliters during these first 12 weeks after ART initiation. And then on the right-hand side, you can see we broke this group up into tertiles according to the extent of decline. So we created categories of mild, moderate, or severe declines in lung function. And for those with severe declines, which was almost 20% of the cohort, they had median declines of nearly a liter, which just for reference would correspond to roughly 20 to 30% of their total lung volume. And then I also just want to point out that while the proportion with abnormal lung function after treatment completion overall didn't differ for those with and without those early drops in lung function, the group with more severe drops actually were significantly more likely to have impaired lung function at the end of treatment, with just over 70% of that group still having impaired lung function. And so this indicates that these early drops, and certainly the large ones, do have long-term consequences for these patients. And these plots depict some of the same data that I just presented on the previous slide, but in a bit more of a visual format. And first, you can see the FEV1% predicted plotted over time. The group that had no declines in lung function is in those gray bars, and those with increasing severity of decline are plotted in those shades of orange and red. And it's worth noting that those who had the early declines did start out with higher lung function, which I think goes along with some of what we think about with people with HIV who get TB, where they'll often have less lung involvement at the time of diagnosis. Looking over at the plot on the top right, though, we've actually plotted the FEV1 as the change relative to baseline. And what you see is that the group who didn't have declines, and even the group with mild declines, did have a gradual recovery of lung function over the course of treatment. And that's in contrast to those who had those moderate and severe declines in lung function, where they never really recovered beyond their baseline at the time of diagnosis, which certainly is a time when they would have been acutely ill with TB-HIV co-infection. On the bottom left there, you see symptoms, the CAP score over time. And I think this plot really nicely highlights that almost everyone felt better, and virtually none of the patients, even those who had impaired lung function after treatment, complained about it. Part of me thinks that symptoms are all relative, and that they probably felt so much better after being treated for their TB and started on ART, that they may have minimized some of the residual symptoms they had. And then last there on the bottom right is a 6-minute walk test, which is a semi-functional test. And you can see that in this case, those who had early declines in lung function in those orange and red shades did tend to have a drop early on in their 6-minute walk test distance, but that they recovered, and that sort of came out in the wash by the time they got to 12 months. And so just to recap this part of it, focusing on TB iris in the lungs, I think we've shown that lung inflammation, at least as measured by PET-CT, is correlated with lung function as measured by spirometry, that TB-specific CD4 cells may be driving some of this inflammation and injury, that clinically meaningful declines in lung function are common after starting ART, but declines in lung function may be relatively asymptomatic, at least in this population. And also that these early declines are associated with long-term pulmonary impairment. These data also, though, can give us a sense of how dynamic lung function can be in this population. And so to try to understand this further, we wanted to focus in on some of the patterns and phenotypes of lung function that we see in TB and HIV. And so with this same cohort, these are the patterns of lung impairment that you see at baseline. And certainly what you're seeing at baseline is going to largely reflect damage that's occurred actually prior to diagnosis and treatment initiation. But with about half the cohort having normal lung function at baseline, about half had abnormal lung function at baseline. And I think it's a little surprising to see that restriction is actually far more common than obstruction. Nearly a third of the cohort had more of a restrictive physiology at the time of diagnosis. And this has been shown in some other groups, but I think just when you think about it, with TB being sort of a coughing, sputum-producing symptomatology, that most of us would gravitate towards putting post-TB and TB lung injury in more of a COPD bucket, and that might not actually bear out. Woo. And so here what you see is symptom involvement, and CT involvement broken down by those categories of which diagnosis they had. And what you can see here is that as compared to those who had normal lung function at baseline, those who had obstruction on their spirometry were not actually significantly different in terms of their symptom burden than those who had normal lung function. Whereas those who had restriction, or both obstruction and restriction, actually were significantly more likely to have greater symptoms at baseline. At the same time, we also looked at radiographic involvement using the CT scans from those PET CTs. And you can see that only those with restriction had significantly more radiographic involvement than those with normal lung function. We then did some logistic regression modeling to model the odds of having abnormal lung function at baseline. And the variables that got included in the final model were the CD4 count at baseline, hemoglobin A1C at baseline, and then that symptom score. And you can see those odds modeled here. And then in a second model that we created, we brought in the CAT scans, which were only, again, done on a subset of participants. And what you can see is that the CT score did have a magnitude of effect that was greater in terms of being associated with greater odds of lung impairment at baseline, even though it didn't meet statistical significance. And here, the only one that actually met that significance threshold was the hemoglobin A1C. And then fast forwarding a bit through the timeline, you can see here lung impairment at baseline, 6 and 12 months. And again, whereas about half had abnormal lung function at baseline, by the time you get to 12 months, that number's gone down to about a third. But from 6 months to 12 months, there's still some changes obviously happening. We looked at how the baseline diagnosis agreed with the 12-month diagnosis, and that kappa of 0.23 is quite poor agreement, which is not unexpected. They're acutely ill at the time of baseline. But even the comparison between the 6-month and the 12-month diagnosis, a kappa of 0.48 is still pretty weak agreement. And so this suggests that really between the time they finish treatment and even 6 months after that, there's still a lot of flux happening. And this graph actually demonstrates some of that flux that's happening in the fluid nature of these changes over time. And so just to walk you through it, it's the same basic categories, although we've also added in patients who were unable to complete the spirometry testing. But what you see on the left-hand side is the baseline data, and the middle is the 6-month data, and then on the right-hand side is the 12-month data. And certainly you see those green bars getting bigger, again indicating that more people are having normal lung function over the course of this. But also even between 6 and 12 months, some people revert from normal back to an abnormal pattern. Some people who were abnormal at 6 months then normalize. And I think, to me, this really underscores that we need to be really thoughtful in how we study these patterns, how we think about timing of interventions, and then monitoring the effect of those interventions, and what timeline we need to include in designing some of these studies. And then as we've done at baseline, we modeled the lung impairment after treatment. And so this is the odds of having abnormal lung function at 12 months. And in the first model here, what you see is that nothing actually met a significance threshold, but that the early change in CD4 count from baseline to 4 weeks, the time from TB treatment to ART initiation, and just having abnormal lung function at baseline all trended towards being associated with abnormal lung function at the after treatment. And then I actually did a second model and reran it where I broke down the baseline categories into whether someone had obstruction, restriction, or both obstruction and restriction at baseline. And was interested and surprised to find that if you had obstruction at baseline, that did not put you at greater odds for having abnormal lung function at 12 months. But having restriction or both obstruction and restriction certainly did. And then last, at least for this section, just to bring back in the MMP thread, here you see the baseline MMP 8 and 9 values plotted against the FVC at baseline. And there's a modest correlation for MMP 8 and no correlation for MMP 9. But interestingly, when you plot these baseline values against the FVC at 12 months, there were significant correlations. They're not the strongest you've ever seen, but it suggests that MMP activity at baseline may actually sort of predict and herald longer-term lung function and lung impairment. And so again, recapping sort of this second section here on patterns of lung impairment, about half of the participants in our study, in the LIFT-IRIS study, had abnormal lung function at baseline, and about a third still had persistently abnormal lung function at 12 months. But as you saw with some of those graphics, lung function is highly dynamic during and up to 6 months after TB treatment. Baseline restriction but not obstruction is associated with long-term impairment, and that MMP 8 and 9 levels correlated with lung volumes at the end of treatment, much more so than at baseline. And I think, these data so far highlight that there are these distinct phenomena happening in the lungs. And in an effort to focus in on some of the local immune response happening within those alveoli, I'll close out with some preliminary data from ongoing work I'm doing looking at alveolar macrophage dysfunction in HIV. As I mentioned at the beginning, these are some data I'm collecting as part of my K23 award. The overarching question for that project is whether people with HIV are more likely to get TB after being exposed. And there's 3 different angles to this. The first is looking at the epidemiology of it. I'll be looking at some rates of TST and quantiferon positivity in HIV positive and HIV negative household contacts of TB patients. And then looking at some T-cell responses, comparing pro-inflammatory, anti-inflammatory, and regulatory cytokines in quantiferon positive and negative, HIV positive and negative household contacts. And then what I'll share today is some, again, very preliminary data looking at alveolar macrophage responses to TB in people with and without HIV. And just to acknowledge some work that's been done by colleagues in my division here at Emory that has laid some of the groundwork for this. This is a paper from a few years ago demonstrating that you can indeed isolate HIV in alveolar macrophages. And on the right-hand side, what you see is that the macrophages that have the DNA in them have a lower phagocytic index than those without. And I should say also that all of the people who participated in this first study were on antiretroviral therapy, and upwards of 80% of them had an undetectable serum viral load. And then bringing in the MMP data, sorry, I'm having a minor technical problem. What you see here are some data from a animal model that some colleagues here use, which is a transgenic rat that expresses GP120 and TAT. And so in these transgenic rats that have these HIV proteins present, in their alveolar macrophages, they have greater expression of MMP9 and lower expression of TIMP1, which is a tissue inhibitor of metalloproteinases. So when you combine those 2 together, there's just generally going to be a lot more MMP activity happening in these alveolar macrophages. And then on the right-hand side here, you can see when you take these same rats and expose their macrophages to a TB cell wall antigen, the HIV model really ramps up the expression of MMP9 as compared to the wild type. And so, again, thinking about that sort of synergy and overlap of TB and HIV and the potential for pathology there. And so for my K23, I'm looking at alveolar macrophage dysfunction in HIV. It's, as I mentioned, a research bronchoscopy study where we're recruiting and enrolling people with and without HIV who we've matched by age, sex, race, and smoking status. So we have matched pairs. They're all quantiferon negative. We wanted to have some homogeneity in terms of the previous TB exposure, and so that's the way to do that. And then for those with HIV, we wanted to really focus in most on those deficits that would persist despite immune reconstitution. And so for those people, we have them on ART for at least 18 months with a CD4 count above 350 and an undetectable viral load. And so here's just some data showing the phagocytosis findings, and these are the 5 matched pairs of HIV positive and negative participants that we've enrolled so far. And unfortunately, what you can see here is that the data are a little all over the place. I put in sort of orange lines the matched pairs who had less phagocytosis in the group, in the people with HIV, but those 2 blue lines show that for 2 of the pairs, the people with HIV actually had greater phagocytosis. And as I have written here, this is an irradiated TB strain. So we're just getting ready to actually start up sort of the second phase of bronchoscopies, and we'll be using a live attenuated strain and repeating some of these. So we'll see how those data bear out as we get a little further along. Thankfully, in a positive note, we have had something that hit, and this is the MITO stress test done on the Seahorse platform. And what you see here is the oxygen consumption rate for the macrophages from people with and without HIV. And that those with HIV who are in that solid line along the bottom have impaired mitochondrial bioenergetics, impaired oxygen consumption, really across the board for their mitochondria. And you can see that across many of these different indices, whether it's basal respiration, ATP production, proton leak, or at the bottom there, non-mitochondrial respiration, these were all significantly impaired in the people, in the macrophages from people with HIV. what does this mean? It means that whether at rest or under stress, if they were faced with an infection or something, these macrophages are less able to do energy-intensive processes, things like phagocytosis, like generating a respiratory burst. And then we've also done RNA-seq and ATAC-seq on these same alveolar macrophages, and these are kind of hot off the press, so very preliminary analyses only done so far. And just the first pass, what we found is that with the RNA-seq, there are 310 differentially expressed genes with a raw p-value less than 0.05, and with the ATAC-seq, there are 98 differentially accessible regions with a p-value less than 0.05. And what I have on the right here, just harkening back to the last slide I showed you with some of those mitochondrial data, are 7 genes that for ATAC-seq have significantly different peak counts for the HIV positive versus HIV negative. And so just to close out here, hopefully I've convinced you that we need to move beyond thinking just about a cure for TB outcomes. If anywhere from 30 to 50% of TB survivors end up with chronic pulmonary impairment, in terms of the global burden, that translates into 3 to 4 million people each year developing incident pulmonary disease, which is a staggering number. The overlap of lung disease and TB and HIV remains poorly understood, and hopefully these data will be part of some foundational data to really build on understanding it better and thinking about studies where we can think about host-directed therapies to try to intervene. And while the lung damage that's happening after diagnosis in these patients is certainly unfortunate, it actually also offers a window for intervention. If all the damage were happening before diagnosis, then we wouldn't have much to offer these people aside from finding them sooner, which everyone is trying to do, but as we know is a gargantuan task. And then I also just want to emphasize the potential for utilizing novel tools and methodologies, things like the PET-CTs, adding spirometry into many of these studies, and then when possible, even trying to build in local samples to understand what on many levels is a local response within the lungs. I'd like to acknowledge many, many people, certainly all the people involved in the LIFT-IRIS study, and particularly Greg. I really have learned a lot from him thinking about TB-IRIS and some of these inflammatory phenomena and how to contextualize many of them. And I've been grateful for the opportunity to work on the study. And then also many of my colleagues here at Emory who have helped with the research bronchoscopy, which the logistics for are not small. And acknowledging funding support from NIAID and also from the Penn and Emory CFARs. And that's what I have. So I'm happy to take questions and have a discussion about some of these points.
Great, wonderful, Sarah. Thank you so much for presenting. And again, just as a reminder, if you have a question, I guess we could do it 2 ways. I mean, if you have a question, you could just, since I haven't gotten any texts yet about questions, you can just unmute and go for it. And if there's 2 people speaking at once, we can sort it out. Sarah, I had a question. So the bronchoscopy study is interesting, both from just a logistical standpoint in terms of how easy it is to get people to enroll to do those studies, which I'd be interested in hearing your thoughts on. The idea as a pulmonologist of doing those studies in patients with TB, for example, we've been on therapy for a while because trying to get, I mean, you can get induced sputum and you can get a lot of information from that, so you don't always need a bronchoscopy, but I'd like to know your thoughts on the feasibility of doing that, for example, in patients who have TB or recently been started on TB treatment. And then a more sort of mechanistic question, have you gotten into any of the genes that you showed as differentially expressed through your RNA-seq data in terms of trying to understand kind of what the functional implications would be of those differential expression?
So the first question on the bronch logistics, we have a wonderful study coordinator here who has been helping us with our research bronch studies for the last, I guess, 7 years that they've been going on. And I think she makes all the difference because she really explains things in a way that participants feel comfortable with. And she has a lot of people who say to her, this was a pleasure. Let me know if you've got any more studies in the future. She's got a couple people who've probably been bronch for research 4, 5, 6 times. As for bronching people with active TB, I don't think I'd be able to get that approved through our IRB or certainly through the bronch suite. You know, once they're if they had culture converted their sputum, that might be an easier sell, although, even clinically when we're bronching people where we're concerned about TB, we usually make it the last case of the day, and there's a whole lot of other implications for it. So I think, it will take a little bit of thought. The group that I've thought about bronching is actually the exposed household contacts, where those are people where, looking at that early local immune response would be particularly interesting. And then, you would catch them before they were even symptomatic potentially, and then you could follow them forward in time and see what happened. And I think that, in terms of logistics would be easier. For your second question about the RNA-seq and ATAC-seq, I have a colleague here who's doing some of the pathway enrichment analyses to try to pull some of this together and make a little more sense of it beyond what's just a list of genes. And that's, literally underway right now, but we don't have that yet.
Okay. Thank you. So any other questions? We have a good group. We have almost 30 people on the call.
Sarah, this is Ron Coleman from Penn. The ATAC-seq changes that you're seeing are really interesting. Do you have any thoughts about what might be related to direct HIV infection versus what is related to a hyperinflammatory milieu?
Hi, Ron. That's a great question. And we haven't really gotten so much into that. And I'm trying to think of how we could. I suppose, another one of the findings that we've seen with these macrophages in people with HIV is that they're under a lot of oxidative stress. And so I suppose we could take macrophages and expose them to oxidative stress, which is sort of a proxy for that inflammatory milieu that you're talking about, and see whether they would have comparable changes in their ATAC-seq. And that might be one way to get at it, would be to sort of have that third arm, so to speak. So
Yeah,
I'll have to put some thought into that.
Yeah, you might be able to look at people with HIV infection without tuberculosis or with some other ongoing pulmonary process, as well as in vitro infected cells.
Yeah, no, certainly.
Interesting data. Thank you.
Thank you.
Good. Any other questions?
Hi, this is Connie Benson from UCSD.
Hey, Connie.
I just had a question for Sarah related to other underlying factors that may affect lung function in people with HIV and TB, and how well you're able to control for things like specifically the minors, what contribution exposure in the mines has on lung function or other environmental factors. I understand there's a lot of work with smoking, but there's a lot of other environmental smoke exposure, other environmental exposures in some of the countries where the work has been done. And I wonder how well one is able to control for that in these kinds of studies. I know it's complicated.
Yeah, no, I mean, it's an incredibly important issue. And, thinking about lung health more broadly, as you point out, whether it's workplace exposures or cook stove exposures and things like that, it's a big area right now. In this cohort that we enrolled, there was actually, I think, 2 people who had reported mine work, but it was less than a couple of years they spent in the mine. So this population, these data I presented, they wouldn't have that risk factor, as compared to some of that background data I presented. And, what we know with the miners is that there's essentially sort of a synergy where the silica exposure that happens in the mines will exacerbate, whether it's smoking-related lung damage or presumably TB-related lung damage. As for how to control for that in these studies we do, I think it, comes down to sort of doing a well-designed epidemiologic study where you, do your homework and try to collect the risk factors so that, again, you'll be able to try to control for them as best you can in the analysis.
Great, thank you.
Hi, this is Karen Jacobson. Can I follow up to Constance's question? Hi, Sarah. This was a great talk. Really exciting to see all the progress you're making. I have to say, I'm really surprised about your tobacco information. And I was wondering if you were as well. We're, doing a study of TB patients in a different part of South Africa, and actually have been quite surprised by the amount of smoked substances, I should say more generally, that we're finding in a convenient sample of patients coming into the TB clinic. Could you just get into a little bit about how these things were asked and ascertained, and if you were surprised at all as well?
Yeah, I mean, the amount smoked is certainly quite low in terms of the overall. As for how they were ascertained, it was during the baseline interview, they were asked, are you currently smoking? If yes, how much and for how long they'd been smoking? And if not currently smoking, if they had ever smoked. If you have other tools that you're using to ascertain that you think might be more sensitive, we'd certainly be happy to hear that. I don't have a good sense of, how smoking varies across South Africa amongst, different ethnic groups potentially. That might be something that we can follow up with some of our colleagues there if they have a better sense of that. So I don't know that I have a good answer for you. Or Greg, do you have thoughts there?
No, I was just going to ask Karen, did you find people were smoking a lot of things other than cigarettes?
Yeah, so that's what we're writing up right now. So we've been really surprised. So we've been working in the Western Cape and outside of Cape Town in Worcester. And we were there because we were very interested in alcohol use. But again, we're recruiting just in the clinic in the general population. What we found is that we were asking, so we asked the Fagger Storm, which is a little bit more information on cigarette use. And we've been asking then also the audit to get alcohol and the DUDIT to get drug use. And we're finding actually a tremendous amount of methamphetamine and methaqualone, which is quaaludes, being smoked in our TB population. And what we're actually finding is we're doing urine drug tests as well. And there's actually not that much underreporting. And so it's definitely overrepresented in this area. And I feel like it would be interesting just to, introduce more of these kind of questionnaires into TB research to further explore. I mean, did we find the one place in the world? I find that hard to believe, but certainly it's raised a lot of interest about how that would be an additional interaction for lung health. Sarah. So.
That's interesting. Good. Anyone else have other questions? Richard, I see we have Richard Hafner on the line. Richard, you're not going to ask about doxycycline? I don't know if he's...
Yeah, I guess I was muted.
Yeah.
Yeah. So what about doxycycline? Have you guys been giving that any thought? Our friends in the UK have been, blocking on his name. Elkington, yeah. Obviously, they've been trying to get something started, but haven't, and it's surprising and a bit frustrating at this point that nothing has happened. So, do you guys have any thoughts on that?
Well, I mean, there's a pretty big interaction with rifampin, so it would probably have to be done with rifabutin. I mean, so doxycycline's been used with rifampin to try to treat brucellosis, and it doesn't work, I think, in part because of a drug-drug interaction. So that there's that layer of complexity. I've always kind of wondered if, you know that there's MMP activity that's upregulated, but it's hard to say. I mean, it might just be correlating with more severe TB disease, and you might need all those MMPs to heal. You don't necessarily know if they're involved in scarring, but I think it would justify, perhaps a small study trying to see if it had an effect. But it would have that layer of complexity of drug-drug interactions. I know that it came up in the host-directed therapy working group proposal to the ACTG a few years ago, and wasn't viewed favorably. But I think it is notable. There's just a lot of data linking MMP activity and a variety of MMP types of activity with lung damage. So I don't know what Paul Elkington and his group are trying to propose.
Yeah, I think they were looking to do a pilot trial at least a couple of years ago and didn't get funded. It's such, obviously it's a benign intervention, which is why that's where the frustrating part comes in, and it might, in people with severe disease, who knows, it may actually be of use. And
Good. Any other questions? Okay. Well, Sara, thanks again for presenting, and did a really nice job of integrating a lot of data in there. And the K23 award research bronchoscopy thing is a really cool effort. Now, go ahead.
Sorry, I forgot what I was really wondering about, and that is, are we missing the boat by only looking at FEV1 in these, our trials in terms of looking at disease and potential reversal by host-directed therapies? Are we ignoring the contribution of the biomarker value of restrictive measuring restriction, or is that just not practical?
Or maybe maybe actually even diffusing capacity, although that's obviously much more challenging and complicated to get. I think that's a good point that was just raised.
Yeah, I mean, as a pulmonologist, I would always love to have more lung function measurements. And for this study, we did actually start out trying to do the DLCO, and I don't think we've been able to pinpoint exactly why, but I think in the first 100 that were done, there were 2 that were actually interpretable in terms of the data that we got. The patients just had a hard time following the instructions. Spirometry is relatively straightforward. It doesn't require quite the same amount of breath holding. And so if you imagine these really sick patients, it's a lot for them to do that. And in terms of the question of sort of obstructive versus restrictive physiology, the caveat that I didn't highlight during the talk is that restriction is not diagnosed based on spirometry. Spirometry can be suggestive of it, but the actual positive predictive value of having restriction on spirometry is about 60%. And what you really need is you need the body box to do full plethysmography to get the lung volumes. And I think, in addition to sort of the financial implications for those, they're a lot more expensive than a simple spirometer. It gets back to some of the question that came up earlier, or sort of came up earlier, about infection control issues, putting a bunch of people with active TB, in a very small enclosed space, one after another. So I certainly think that we need to be creative in thinking about how we can get more complete measurements, and again, better understand some of the patterns that we're seeing and how the inflammation that we see, how all the sort of circulating biomarkers translate into these functional outcomes. And I just think it, requires some thought and some creativity, and making sure that, we're not putting anyone in harm's way in our efforts to get at these measures.
Yeah, and I think, Richard, I would add too, I think we're trying to work on some collaborations to validate some of the findings that Sara presented there with respect to symptoms, because if you have abnormal lung function without symptoms, you're doing better than if you have abnormal lung function with symptoms. And typically decisions to treat COPD, for example, are based on the presence of abnormal lung function and symptoms. And our finding that restriction was much more likely to be associated with worse symptoms, I think, is something that we want to follow up on in other cohorts, because I think, if you, I think maybe, typically in the HTT trials that I've seen, and I know in, you get the FEV1 and you get the FVC as well, so you can look at both. But I think we should be thinking along the lines of FVC changes at least as much as FEV1 changes, as Sara emphasized. If there are no more questions, I don't know if there are, but if there are no more questions, we're at the top of the hour now. Again, thank you, Sara. And thanks everybody for joining. We will plan to have another one of these in about 3 months, so in January sometime. And the idea, which I think is a good one, has come up to invite some of our colleagues who are from the Report Network, which has been presented to the CFAR group before, which is a network focusing on TB globally. Have one of our colleagues from the Report Network present some of their data. So I think something a little bit different, expanding a little bit outside the CFAR network into Report as a way to foster collaborations. So look for messages on that for the timing. And just to emphasize, this is a group that if people just email me and say they want to be part of the group, they're part of the group, and I'll put them on the email list. So thanks everybody for dialing in. It was a very interesting discussion, and thanks again, Sarah.
Great, thanks so much, Greg.